Welcome to Designing Healthcare That Cares, the show where we explore how to build healthcare systems where people and performance thrive. I'm your host, Dr. Laura Sutton, a physician, coach, and healthcare leader who believes that human flourishing and organizational excellence go hand in hand. Each week, I talk with leaders, change makers, and innovators about how to shift culture, lead with purpose, and tackle the root causes of burnout. Because when healthcare works for the people in it, everyone wins. Welcome to the Designing Healthcare That Cares podcast. I'm so excited to have my guest on, Dr. Chantal Lorio. Let me go ahead and introduce Dr. Lorio. She has over 30 years of healthcare experience, and she has seen how powerful communication can transform patient care and clinician well-being. As an executive coach, she's helped physicians and healthcare professionals strengthen relationships, improve outcomes, and rediscover purpose in their work. She is a professional certified coach with master's degrees in leadership and healthcare management. Her mission is simple: to help healthcare professionals feel understood, supported, and equipped to deliver care that heals both patients and clinicians. And she has a new book out that I'm super excited to talk about. Her new book is called I Get You, I Got You: The Secret to Creating an Empathic Connection with Every Patient, Every Time. Welcome to the podcast. It's good to have you.
Thank you, Laura. It's great to be here. Great to connect with you again. It's been a little while since we've talked. So
It's probably been about 4 years when I first joined as a part-time consultant. I joined the Huron Consulting Group, and you were a seasoned consultant at that time and helped to orient me and helped introduce me to the team. And I feel like we shared a passion at the time for
yeah.
patient care. And so just really excited to talk to you. I can't believe it's been that long. I'd love to hear, and for our listeners to hear, tell us about your journey. How did you get to where you are now? Start from the beginning.
Okay. So you mentioned Huron. That's where I currently work. Prior to working at Huron, I was at Oxford Health. So again, I've been in healthcare for 30 years, but I spent 16 of those years in private practice and doing some leadership roles as well at the community hospital. But then I was recruited over to Oxford to be a department chair, but developed an interest in patient experience. And we had partnered actually with Huron at that time. And I sort of became the liaison physician with Huron. And they really taught me how to enhance patient experience, how to coach physicians and providers and give them feedback, which is actually, I don't know how easy that sounds, but it's not. It took some nuances in developing that skill to be able to give healthy feedback that was readily received and then obviously implemented. So I spent several years doing that and then became the medical director of patient experience for the Oxford Health System. I did that for many years, and we developed a whole internal coaching program, not just with physicians, but we had multiple coaches who coached everyone in the organization, even the non-clinical team members, so that as we interact with patients, that we all learned how to make connections with them. And once Asha got to a point where I felt like we had made a difference, I ended up wanting to expand that and worked with Huron so that I could work in different organizations to help them as well with their patient experience. But I discovered a lot of really interesting things when doing those one-on-one coachings and observing the physicians in real time with their patients. And I started seeing patterns and I said, wow, I knew I always kind of struggled with that, but I didn't realize that so many other providers struggle with the same thing, you know? And it was really interesting. How could I help them in their interactions? And I was experiencing the same thing. So I was sort of utilizing some of the things that I experienced and then what I was seeing and put that all together and created a book that I hope can, from here on out, help other physicians and clinicians and providers with their patients. So that's kind of my journey,
Yeah.
how I got to
Yeah.
here.
That's so cool. And just what you said about realizing that you were struggling with a lot of the same things that people that you were coaching were struggling with. You had a lot of the same
Yeah,
questions. And so it sounds like you're learning this together, figuring it out
exactly.
together, and just
Exactly.
highlighting that it's a ubiquitous challenge, right? A lot of physicians have is that communication. I want to really dive into that, but the communication, and we talk about patient experience. And again, I want to get your really how you define that. But this is something that, at least in my training, it wasn't taught. We were talking about this before we hit record, that you're trying to get your book in the curriculum of clinical schools, medical schools, and
Mhm.
because this isn't something that's taught. I remember when I was in medical school, it was almost like a club you could join where we met, I think once a
Mm,
week. And she was a clinical psychologist. And essentially, she taught us how to deliver bad news. And we
mm,
would
mhm.
practice. And I trained in Houston. We would go into the waiting room at MD Anderson Emergency Department, and we would find somebody there and just sit with them and listen to them and
Wow.
listen to their stories and just be with them. And we couldn't do anything about it, but
Yeah.
just to listen to them and help them. I mean, you think about MD Anderson Emergency Department, again, what a unique opportunity to
Mm,
practice those skills there. But that was my soapbox. All that to say is reinforcing that that's not something now I trained a long time ago, but it sounds like that those skill sets are still considered, maybe the soft skills are not seen as really critical as we develop our clinicians. So I definitely want to hear your perspective on when we say patient experience, what does that mean? And then how does communication fit in there?
yeah. So the Barrel Institute, they have this definition. I'm not going to quote it exactly, but it's basically the sum of all experiences throughout the journey.
Mhm.
So it's not just the communication; it's the sum of everything that happens. So that includes quality and safety and communication. It's all the sum of those interactions become the patient experience. I thought it was interesting what you said earlier about you were listening to patients, but you couldn't really do anything. And it's one of the reasons why I really focus on empathy because we are so focused on what we can do for people,
Yeah.
which is compassion. And my book really talks about the distinction between empathy and compassion. Compassion is, I want to help you, and this is what I can do for you.
Yeah.
And so we come into our interactions with this agenda that I want to help you, and I'm going to do what I can to help you. And so that remains our focus. Work this problem up, get a diagnosis, here's a treatment plan for you. Got it all ready to go. That's my agenda. The patient's agenda, yes, they want to be taken care of, but they also have this, I want to make this connection and help you understand what I'm going through.
Yeah.
And if you don't acknowledge that, if you go right to the helping, which again is compassion,
Yeah.
I hate for physicians to think that, we're the bad guy because, if we don't get a good score and patient experience, something's wrong with us. And you hear these, we get a bad rap, I think, a lot of times on maybe no bedside manner. But what's really happening, and this is one of my great discoveries in this work, is that it's not that we're doing anything wrong. We are coming in there with our compassion. That is why we're in this profession to
Yeah.
help people. We come in there with that agenda. If we can pull back for a second and make a strong, powerful connection, which only takes about 3 seconds, okay? A strong, powerful connection before we do that, the entire experience can be changed.
Yeah.
And why is that? Because when you do that, when you take that minute to make that connection, you build trust because the patient suddenly sees you're on their side from the get go. There's not this barrier of you have your agenda and they have their agenda. You connect that agenda right away. Now they trust you because they see that you're on their side, that you get them.
Yeah.
And that's where my book, I Get You, I Got You. So I get you is the empathic piece. I get you before I got you, and I want to make you better.
Yeah.
And why is that so important? Why do we want to create trust? Well, when a patient trusts us, think about the things we get from a patient when they trust us. What do we get from them?
I mean, we get their compliance, right? I mean,
Yeah,
they follow the directions, the recommendations that we have for them.
exactly. And that's how we get to better outcomes.
Yeah.
If they trust us, we're going to get compliance from them. We're also going to get honesty from them. And a lot of times we don't, right?
Right.
If they're not too sure about us, and how important is that? That
Yeah.
they tell us that real history, that we know what's really going on. And we've only got a few minutes to connect with them. So really utilizing that initial, when we first connect with a person, if we really utilize that to make a strong connection and build that trust, it's going to help everything else in the entire encounter and ultimately lead to better outcomes.
Yeah. That honesty, I appreciate you pointing that out. When I would have patients that would admit to me that they weren't taking their medications or weren't following through with whatever recommendations I had for them, I would actually thank them because I know it takes a
Yeah.
lot of guts for them to come out and admit.
Mm,
And sometimes they would be afraid that I would get mad or something. And so I really appreciate that you mentioned that because I feel like that's more impactful than compliance is their
yeah.
honesty and
Yeah.
really them sharing what they need from us. And I appreciate what you said about or calling me out on, yeah, I said I couldn't do anything for those people sitting in the waiting room in MD Anderson emergency department. And yet I know, and I remember very specific examples of people that thanked us just for sitting and listening. to them. And so I know that we did do something for them, and that jump to saying, well, I couldn't do anything for them. I see this in clearly in myself and in my clients and in my work, that as clinicians, we want so badly to fix it.
Yeah.
And when we
Yeah.
can't fix it, then we get really frustrated and we feel like it's a personal failure. And at least in my part, it feels like if I can't fix this patient, then I've failed them. And that means I failed myself because
Yeah.
there's such an emphasis on those outcomes. And that's not always possible in medicine.
Exactly. And that's another reason why if we just focus on compassion, if we just focus on fixing people and helping them with a medical problem, what happens when we are unable to do that? Have we done
Right.
nothing for them? So if we focus on both the compassion and the empathy, then sometimes that's all we have to offer. If someone's at end of life and we've done everything we can, all we have to offer them at this point is our empathy, is being there with them, connecting with them emotionally. So, that's just another reason. I think there's so many reasons why we need to make sure we insert empathy with every patient every time intentionally.
Yeah.
And that's one of the things I teach too is how do you do it intentionally? Even when things aren't horrible, when someone's just coming in for a checkup, how do you insert empathy when someone's coming in for a checkup? And sometimes it's just as simple things like, gosh, I'm sorry I was late, doctor. Traffic out there was backed up for miles. Oh, that must have been really frustrating, huh? Yeah. And so just that moment of connection that, oh, I kind of get you. I
Yeah.
get what you're going through, rather than just saying, no problem. We're not running behind today. No big deal. Rather than just saying it's okay, taking that as a moment to really look for opportunities to connect with people. It's important for that reason is that we want to build some trust with them. And you don't always have opportunities, so you look for them.
Yeah. And in your title, you talk about every patient every time. My guess is there's some intentionality built in there that there's resistance on, for whatever reason, on us as clinicians being able to do this with every single patient every time. What do you think
Exactly.
gets in the way?
Yeah. So it's one of the reasons why I tell people to do it first. And if you think about it, I kind of remember when I was in medical school, the first time you go into a clinic room for the first time, like you're getting ready to knock on the door. It's like, wow, I'm getting ready to take care of a patient. I remember that moment. Like this is a little stressful, right? And our goal is going in there and like, said, I hope I can diagnose it. I hope I can treat it. Well, most of us have that down by the time we're practicing, right? We know how to diagnose and treat. But if we make our goal when we first get in to build trust, to create that connection, like immediately, I want to build a connection, then we really don't have to think about that anymore. So do it in the very beginning. I want to focus on the connection, make the connection first, and then focus on the diagnosis and treating because the two can get very intertwined. And you can really lose sight of either one of them if you try to mix them up. If you do, though, focus on building trust initially and you focus on how to speak empathically, then it will become part of what you do. Then you can do it throughout. So I always say, make it your focus in the beginning, build trust by creating a connection. And then over time, it'll become natural, just like diagnosing and treating. And then you can mix them up because the pushback that you get from physicians when you say, you need to add more empathy or compassion. The first thing that comes into mind is time for all of us, right? I don't have time for all that. And that's why I even focus on, you can do it in 3 seconds. You can put a hand on a shoulder and create an empathic connection.
Yeah.
Sometimes it's a gesture,
Mhm.
but I also teach the language of it and it doesn't take long. It can be very quick, but very powerful. And then that way it doesn't interfere with all the rest of the things that you're doing to diagnose and treat.
Yeah. You said something that I want to get back to because I feel like this is probably on a lot of clinicians' minds. And again, getting back to the patient experience. And I could not agree more with what you said in the Barrel Institute, and that it's the sum of all the experiences. It includes quality, it includes safety. One of my roles at my previous organization was overseeing our clinical safety team.
Mhm.
And that was something that I was consistently trying to drive home. In a value based care environment, we had a very strong focus on patient experience because it impacted star ratings. And I want to get back to that too, but helping our leaders to realize that safety is a part, it's not separate from patient experience. And if patients, maybe they have a great experience, but it's unsafe, they're happy, but they're not in a safe environment. That is not what we mean by patient experience. And
Yeah.
it's really the sum total. And so I want to get back because I feel like in conversations with physicians and leaders, they hear patient experience and they think of Press Ganey or CAPS
Mhm.
or
Yeah.
whatever scoring methodology they're using. And so help us to tease that out a little bit? I hear, and I'm sure you hear too, resistance from clinicians about, well, if I just gave all the patients they want what they wanted, then I wouldn't be practicing good medicine. And like you said, I don't have time
Yeah,
to, this is not a hotel, this is a hospital. And so help us break that down a little bit more. Cause again, I'm sure you hear a lot of those comments from clinicians too.
I do. I heard it many times over the years. And I will say, for starters, it's one of the reasons we got away from using the term patient satisfaction,
Right.
because that's not our job, right? To
Right.
just satisfy people.
Right.
No, it's the experience and it's the engagement. It's making them part of their care, getting them involved in their care. So that's really, when we're talking about patient experience, that's what we're talking about. We're not talking about giving them what they want. That's dangerous. Really, it's just say, oh, let me give you something to make you happy. So a couple ways we can go here. Let's talk about, for example, person that wants pain medication. Okay. And it's not appropriate. Let's say, it's something that we do. Clearly, this is not appropriate. And that's all they want, right? It's the only thing I want. No, doc, it's the only thing that helps me. And we know that the narcotic is not what they need for this particular patient. So I've had a lot of people ask me, well, what do you say to that? How do you respond to that? And I tell them that if you get to the point where they're asking for it, then it's too late to come up with a magical phrase. There's not a magical answer at that point. They're not going to be happy. But if you start by building the relationship in the very beginning, if you start by building trust, remember we said that they're more likely to comply. They're more likely to accept the things you tell them if they trust you. Do you focus on that in the beginning, regardless? If they come in here and you know that they're going to walk out and sell it on the street corner, okay? If you know that, still treat them from the very beginning without judgment, asking them what's going on, acknowledging that must be very frustrating, very miserable, what they're going through, and make that connection in the beginning. Then by the time you get to that discussion on treatment plans, they're more likely to accept when you tell them, listen, I care about you and I care about your safety. And this is what I think is best for you. I'm worried that if I give you that, it will create a problem for you. And I care about you too much for that. And so again, using the patient experience and the connection in the beginning ultimately can lead to the ability to say no. So it's almost the opposite, is that you now are able to say that is not safe for you because they trust you a little bit more. It's not a perfect answer,
Right.
but it puts you in a better situation if you build the trust from the very beginning. I think that kind of makes that connection there. And again, they do go hand in hand. There's a chapter in my book toward the end that talks specifically about safety and how we use it on safety rounds. And this was one of the things that blew me away. And that where I said, I got to write a book on this because it just blew me away. I was asked by the vice president of medical affairs to join him on safety rounds because he loved all the stuff that we were doing. He was learning how to speak empathically. And he said, I do safety rounds. If you want to join me on those, and we'll use some of the patient experience stuff there. And maybe it'll help with the overall patient experience. So we just used it for that reason. Hey, we'll just have some more patient interactions and improve our hospital's overall experience of care. What we found, just sort of happenstance, we found that when a patient was telling us, part of those rounds is checking the lines, right? Checking all their lines and then asking them, how are we doing? Is everyone taking care of you? Are we treating you with respect? Any concerns that you might have? And what we're hearing is, oh, everything's great. I love Osher. All my patients come. All my family comes here. I've been coming here for years. Everything's great. We love you all. Okay, great. And if you took a moment to connect with them on what they were in there, for example, and let me just give you an example of what this sounded like. So yeah, everything's great here. We don't have any complaints. Everyone's treated with respect. So how long have you been in here? Oh, I've been in here about 3 days. This is my 7th admission in the last 3 months. I have heart failure, and they just keep putting me in and out. Oh my gosh, you've been here 7 times in the last 3 months. Oh, that must be awful, huh? Yeah, it sounds pretty miserable. Yeah, back and forth. I've been through a lot, doc. Yeah, it sounds like that. Doc, actually something did happen the other day. I buzzed the nurse and she kind of hung up on me and I felt like, wow, that was really rude. And I feel like that could have created a situation if I needed them urgently. And they just were really rude to me and hung up. And when we walked out of the room, I apologized for that and said, I'm going to talk to him at the front desk. We'll see what happened and make sure it doesn't happen again. But when we walked out of the room, we looked at each other and we said, did you notice that as soon as we showed them empathy, they became honest with us? It was like they trust us now to tell them what was really going on behind the scenes. And so then we started saying, okay, let's see if we can reproduce that. And we did, like over and over again. When someone wasn't opening up to us, it was like, we just walked in here and started asking questions. They don't know who we are.
Yeah.
But if we took a minute to make that connection with them, all of a sudden they were honest with us with stuff that really mattered, that we could make a difference, and that ultimately could create a medical positive outcome by doing that.
Yeah.
So blew me away. So
Yeah.
that made the connection between patient experience and safety, like right there in the moment. It was really
Yeah.
powerful, really powerful.
I love those stories. And what comes to mind for me is without that empathy, then they might think that, well, they're just asking these questions. They don't really care. And yeah, this thing happened, but if I tell somebody, no one's going to do anything about it. And it doesn't matter. And so you've created that connection. So you've pulled them in, you've brought them in, you've made
Yeah,
them feel seen and heard. And that allows them to open up. That's really, really interesting.
it was really cool. Yeah,
Yeah. What about the connection between this empathic communication and clinician burnout? What are
yeah,
you seeing there?
yeah. So, and we're going to bring compassion and empathy together for this piece.
Mhm.
There's many studies, and in fact, if you've ever read the book Compassionomics or Wonder Drug, there's a lot of strong. I'm sure you've read. There's a lot of strong connections there between compassion and empathy. I mean, between compassion and well-being. But we see the same thing with empathy, and so I've found a lot of articles that show very similar results. In that, while you think I don't have time for all that, it's going to be draining if I live the moment with all my patients. Yeah, if you did that, if you fell apart crying when your patient's falling apart crying, that probably would be pretty disastrous for you, right? But learning how to make those connections just by acknowledging, and that's really a lot of what empathy is, acknowledging an emotion. It's not living the emotion. It's just acknowledging it. So being able to identify it, oh, that person is really sad or upset about something, and then acknowledging it sounds like you're really upset. That's not diving in and taking on all their emotions,
Yeah.
you know what I'm saying? And I think that's why we don't see in the literature what people are afraid of, that we're afraid that it's gonna create burnout, and in fact, it does the opposite. And I know you and I can both, and I'm sure most physicians can acknowledge that when we've had a rough day of interactions with patients, difficult conversations, patient was upset with us or angry for whatever reason, how do you feel when you come home? You don't feel great. Right?
Awful.
Yeah, and we just don't feel great when that happens, and so I think we could all speak to the fact that if our interactions go well, we have a good day. It's a good day, and so I see that as also something that sort of correlates to patient experience and well-being.
Yeah. Yeah. It's a win-win-win, really, all around. And I love how you were sharing, like, it doesn't take much time and breaking that down and talking about patient satisfaction, how we don't use that term anymore. It,
Yeah.
I think about my own leadership experience and when I was in some of these roles leading some of this work when the patient the we called it like a customer satisfaction and we were really looking, it was about 10 years ago,
Mhm.
really looking at that piece. And I felt like, I don't know if it was just my organization, but we did get away from what really is patient experience. And it's not just giving them everything that they want, but it's the whole package. And then including the clinician in that too, thinking about the quadruple aim is that
Mm.
remembering that if we are not taken care of, if we don't take care of our own mental health, and if or not even in mental health, but our own well-being, and if we're not in a system that supports our own well-being, then we can't provide the
Yeah.
empathy for the patients. So I'm excited to read your book. I haven't read it, but I'm excited to read it just
Yeah.
because I know
Oh,
you and I know it's going to be incredibly helpful to clinicians. And so super excited and congratulations to you.
thank you. I know I'm doing a lot of teasing here for you, so be interested in doing it. One of the things is that the book really does explain how to speak empathically because I think most people just assume if you say, I'm so sorry, that's an empathy, and it's not. And saying, I want to help you is not empathy, that's compassion. So, really, I spend a lot of time helping people understand the differences in those three terms sympathy, empathy, and compassion and why it matters to use one versus the other and when to use it. And so, yeah, I'm teasing a lot. There's a whole lot more in there. And I think one thing that we all need to be aware of too is that everybody in healthcare, well, really, in industry right now is all worried about AI. How is that going to affect us? Who's going to lose their job over AI? And I really think we need to be thinking about how do we partner with AI? How do we create incredible healthcare using what we have that AI will never have? AI is going to learn an awful lot. I mean, we're going to have robots that are going to mimic so many things that we can do, and they can hold so much more information than we can. But there is one thing that AI will never be able to replace, and that's our humanity. It's that our ability to connect on a human level, one human to the other. And so I see us in the future as being that liaison between the artificial intelligence and the patient, and being able to bring the humanity to it and present it in a way that a patient feels taken care of and cared about, that it can't replace humanity.
Right.
It will mimic as much as it possibly can, but it cannot replace humanity. So this is so important for us in this time of bringing AI into healthcare, is that we recognize that that will always be our role. And those who perfect it, I think, will be those are the ones that are going to really succeed in healthcare in the future.
Yeah. So important. Thanks for bringing that up. And even without AI, if we just think about how automated so much of healthcare is and how our technology is advanced, and, I get text messages all the time. I used to get phone calls, which is fine. Prefer the text messages,
Yeah.
but we've become so much more automated that those pieces of humanity in certain situations and certain interactions is now a screen rather than a human. And so, how do we make sure that we're still keeping that humanity in our healthcare interactions, in our healthcare environment, and amplifying it?
Yeah, that's why I teach the language. It becomes so much more important when you're in virtual. You lose that ability to use human touch. So the language then becomes even more important. So I do teach that. That's one of the reasons, is that you can use your language to create empathy with the patient and connect with them.
Yeah.
So yeah, so I think that's a whole nother level, is that we're doing things digitally. But I always thought, my children are all grown now, but they were millennials and one's a Gen Z. They're in their late 20s, early 30s. And I thought that they're so, they grew up with digital. I thought they'd be so focused on digital when it came to healthcare that they would never want to go to a doctor. But you know what? When they get scared, and I do find that generation gets a little more nervous about their health. And I'm not sure what's behind that, but I do think that they get a little more nervous than we do about healthcare. And they want to go to the doctor. They want to go be seen when they're scared, when it's something they're worried about. They want to make that appointment immediately,
Yeah.
or they want me to make the appointment immediately, or whatever. Usually it's, Mom, will you take care of this?
Yeah.
So I do find that I think we don't give them enough credit for how much they do like that human interaction, especially when they're scared. So they might like to order everything online, but when they're scared, guess what? They want somebody in person.
Yeah. So important.
Yeah. Yeah.
Thank you so much for being here. Where can our listeners find you, and where can they get their hands on your book?
Sure. Well, I'm on LinkedIn and Facebook under my name, and I have a website, www.drchantallorio.com. And my book's available on Amazon. You just got to search my name.
Awesome. Thanks so much for being on with us.
Thank you, Laura. I enjoyed it.
Thanks for listening to Designing Healthcare That Cares. If today's conversation gave you a new idea or inspired you to see things differently, share this episode with a colleague and keep the conversation going. And if you're ready to take the next step in building a thriving healthcare culture, you can find resources and ways to connect with me at drlaurasutton.com. This podcast is for educational and informational purposes only. It is not medical advice, and it should not replace care from a qualified healthcare provider. Always seek the guidance of your physician or other qualified professional for any medical questions or decisions.